Well, good afternoon, everyone. Can you all hear me? Can I just check? Perfect, great.
Yes.
Great, thank you. Good afternoon.
Yes.
I'm Asha Hamid. I'm one of the supportive care consultants at the Christie Hospital. I'm chairing this webinar, this very interesting webinar on oral mucositis. Before I go any further, can I request everyone to mute their mics, please? Thank you. So we've got an amazing area of speakers who are going to give us an overview about mucositis and how we can manage it effectively. Next slide, please. Great. So we've got Joss Harding, who's a dental hygienist at the Dental Care and Implant Centre in Gloucestershire. We've got Joe Thompson, who's a nurse consultant at the in supporting palliative care at the Royal Surrey Cancer Centre. And we've got Sonia Hoy, who's a divisional nurse director at Royal Marsden. So next slide, please. Next slide, please. So we're going to kick off with Joss giving us a brief overview about mucositis and how it can be managed. Over to you, Joss.
Thank you very much. So thank you very much for listening. This is going to be a very brief overview of oral care and how we can help patients through their journey and possibilities of oral mucositis and the problems that can give us, potentially long term, because as we know, dentistry is a hot potato at the moment, so prevention is key. So next slide, please. So when I look around patients' mouth, I'm looking to see if they've got teeth, how their gum health is, and if they have good saliva flow. Next slide, please. But the one thing that can change this is oral mucositis. It's very difficult to have good oral care with oral mucositis. So I'm going to give you quite a few suggestions and explain why problems do occur within the mouth. Next slide, please. And next slide, please. So is oral care important? Well, for me, for all my patients, I think it's vitally important. Is it important to patients during the cancer journey? Possibly not. So how effective is the patient able to clean their mouth with oral mucositis? It can be very problematic, as all of you know that work in this area. It may not even be a possibility. So what are patients using for cleaning their teeth? Are patients cleaning between their teeth? And are patients wearing dentures? And what is their dexterity like? And does the patient have support? Are they actually able to use their toothbrush and cleaning materials themselves? So next slide, please. So the evidence-based guidelines for primary and secondary care in dentistry are on the following slide. So next slide, please. So we go to gov.uk. So this is the third edition of Delivering Better Oral Health Guidelines. So this is an evidence-based toolkit. It's great. It covers all areas of dentistry. So please feel free to look at this guidance, especially for looking after our high-risk patients who may have all sorts of issues and problems, as well as having a cancer diagnosis. The Royal College of Surgeons guidelines here in the middle from 2018, a great document again, mainly hospital based, so looking after patients before, during and after their cancer treatment, and the EUCOMIC guidelines. So the third edition, this is a great document created by medical and dental professionals together, again, easy to get hold of online. And these last two are currently about to embark on another update. As we know, things are moving fast, and especially when it comes to dentistry and oral care for this area of patients. So next slide, please. So a rather graphic photograph, I have to say. So for many patients who are starting their head and neck cancer journey, a lot of these teeth will be removed because they are unrestorable. But some patients who are on their other journey are not head and neck, have a diagnosis for other areas of the body. They may begin their journey with teeth like this and end their journey with teeth like this. And are they able to look after their teeth, and how problematic is it going to be for them to have treatment afterwards? So next slide, please. I'd like to explain a little bit more about tooth decay. So why does tooth decay occur? So tooth decay is a multifactorial disease, and this is what I'll explain on the following slide, please. Now, I'm going to keep it simple. You need a tooth, you need bacteria, you need carbohydrates, and you need time. And the four of those things will mean that the patient will be high risk for tooth decay. And there's a little morph here, I think. So next slide, please. And the most important one for these is time. And even for my patients who are extremely good patients for keeping their oral hygiene as good as it can be, they are on it. I know that when they have a cancer diagnosis, this is the one thing that will change: time. They won't necessarily be eating their breakfast, lunch, and evening meal. They won't necessarily be brushing their teeth morning and night, and they won't be using their interdental aids, possibly. So it's important, this. So this is why tooth decay occurs, but how does it occur? So next slide, please. And next slide, please. So have any of you heard of the Stefan's curve? This will affect you, your family, your friends, and your patients. This will help you understand why people get tooth decay. Enamel is the hardest substance in the body. It takes the dentist a diamond drill to be actually able to drill into it. However, what we eat and drink through the day creates a risk. So next slide, please, although this is the same slide. So if you remember your pH scale from school, the pH scale obviously is above 7 is alkaline, below 7 is acidic. So every time you eat or drink something, whether it's natural or added sugars, the bacteria that cause tooth decay take in those sugars and metabolize that and creates a drop in pH. And it drops below 5.5, and this is called the critical pH. So it drops down, and after 35 to 45 minutes later, the calcium phosphate ions in your saliva help to repair the damage. So this is what happens throughout the day. So you might have your breakfast, lunch, little sneaky coffee or tea in the afternoon with some biscuits, and dinner. But for our patients on their journey, next slide, please. Next slide, please. And next slide, please. So there's a few little arrows here. So the drop in pH, demineralization of enamel, so softening of enamel, and then hardening of enamel. So next slide, please. This could be yourselves on your 12-hour shift. This could be a patient who's not able to eat their breakfast, lunch, and evening meal. They have a terrible acidic taste in their mouth. They have a salty taste. They have a metallic taste. So they're drinking juices through the day. And this will create a constant demineralization of the enamel where it may not even come above the 5.5. So here we have 5 more arrows. So keep pressing the 5 arrows for me, please. On the next slide. So drop in pH. So what's the chance of their teeth actually becoming remineralized and hardening back up again? These patients are very high risk for tooth decay. So we have to look at what are they actually using and what is our role. Next slide, please. And next slide, please. So what is our role? Well, it's good to look at what patients are actually using. What are we using ourselves? Should they be using electric toothbrush, manual toothbrush, and what state is it in? So I don't mind what people use as long as it works. There's lots of research out there that compares manual brushes and electric toothbrushes. You know, it depends how a patient is actually using something themselves. So I always ask them to bring in what they're using so I can just have a sneaky look. And then if you go to the next slide, please. So there are a plethora of electric toothbrushes and manual toothbrushes. Are they able to use that? Are their mouths very sore with oral mucositis? They might want to move to a water irrigator. Are they able to use that because that's too harsh? There are other options for different things you can use. So where the pink block here is here with the 360, that's a particular brand, Orally 360, where it has brushes all around the head of the manual toothbrush. So they're able to, even if it's to remove slough, it isn't there. It can be used for cleaning. There's smaller ones for children, or to the right of that, you've got little silicone brushes. So they aren't necessarily toothbrushing cleaning aids, although they can be used. They are generally for cleansing. So you can use them with different products on, so you can get them into maybe different areas if possible, if the mouth isn't too sore. Are they able to use something between the teeth? Are they using little silicone brushes? Are they using interdental brushes? Are they flossing? Are they clean their dentures? It's so much to think about. And when a patient is fatigued and they have oral mucositis, this potentially will go out the window. But if they're able to, when they're feeling a bit better, if they're able to get back into a good habit of using something to clean between the teeth, that's great. Because when you're not, you're missing up to potentially 40% of the tooth surface. That bacteria can be inhaled, can move all around the body and create issues elsewhere. So for me, it's paramount we keep the mouth as clean as possible when possible, which isn't always when patients have oral mucositis. So if we move on to what else we can suggest. So next slide, please. Next slide, please. Okay, so I'll talk you through toothpaste. Back one slide, please. So toothpaste. So what is there out there? There's a plethora of toothpaste. So in these bubbles here, I just wanted to explain the different amounts of fluoride in toothpaste. So 1,000 parts per million for children up to 3 years old, just a smear on the toothbrush. 1,450 parts per million is generally what most toothpaste have in the market in the UK. When a patient is starting their cancer journey, I tend to move them straight onto a high fluoride prescription toothpaste, of which there are the two strengths. So the 2,800 over 10, and for those over 16 can use the 5,000 parts per million. So in the UK, it is on prescription. So have a look at what the patients are using, because it helps to massively reduce the risk for tooth decay, especially on the root surfaces of the teeth. There are fluoride varnishes available, so that's 22,600 parts per million there. So patients may well, if they're continuing with cancer treatment and they're seen in cycles, they may well be offered a fluoride varnish to be applied to their teeth. Next slide, please. So mouthwashes. Often you'll see somebody toothbrushing, mouthwashing straight afterwards. A mouthwash on average in the UK is got 225 parts per million of fluoride. Some have 500 parts per million. As you can imagine, that's far less than what is in a toothpaste. So don't use it straight after brushing. Use it at a different time of day. If a patient is vomiting, you do not want them to be brushing straight afterwards, because all toothpaste have an abrasive, and the abrasive will scratch a softened tooth. So if they're able to mouthwash, maybe, then that might be an easier option, just to freshen their mouth if they're vomiting. Next slide, please. Mouth sprays can be very effective, depends how patients are using them. So there's lots of videos how to use them effectively. Often patients will spray them straight on the tongue and then they find they don't work. So use of them is important. Next slide, please. So xylitol mints and chewing gum, useful for anybody and everybody. The bacteria that like to take in sugar and convert it to acid, when they actually take in xylitol, they're not able to metabolize it, so they actually die. So xylitol, natural alternative sugar, great for diabetics and very safe to use. So have a look, there's plenty on the market. Next slide, please. There are pastils and lozenges available. Just be aware that when you do have a title on the box that says stimulant, it will be a low pH. It works really well. It may be short term for those dentate patients, people with teeth, but ideally for be used for patients without teeth. Next slide, please. Tooth mousse you may or may not have heard of. Tooth mousse and various products like this are often got milk proteins in, and they're very good for rehardening the teeth, and they can be applied like a little ointment very frequently. Again, if a patient is vomiting, not able to brush the teeth, not able to manage a mouthwash, a tooth mousse application can be quite good. So next slide, please. So somewhere I often recommend patients and professionals to go to look at what is available for saliva substitutes is the specialist pharmacy service. And on these next 3 slides, there are lots of options. Next slide, please. But they also give you lots of information. So they give you the information about the pH, whether the product contains fluoride, does it have any animal-derived ingredients, if it contains gluten, if there's sugar, what's the sweetener, and what the cost is. So although you may not be using these, you may recommend these, or you may be recommending them, I think all this extra information is valuable. So I often show people this link. Next slide, please. Next slide, please. Next slide, please. So thank you very much for listening to my very short section about oral care and products and help. Thank you.
Thanks very
Thank
much,
you.
Joss. Thanks. So
Thank
my
you,
name,
Joss.
sorry. Thanks.
Sorry.
So
Thanks.
my name's
Sorry, Joe, before we go on to Joe, just to remind, if you got any questions, please type them on the chat, please. And we will go through the Q&A session at the end of all the presentations. I will pick some questions that you put on the chat section. Sorry, Joe, over to you now.
No, that's right. Sorry for jumping in there, Ash. Thanks, everybody. As Ash said in the beginning, my name's Jo Thompson. I'm a nurse consultant in supportive and palliative care at the Royal Surrey. Next slide, please. And I'm going to talk to you for the next 10 to 15 minutes about some guidelines, a bit of an overview. And these are guidelines that have been produced by MASC, the Multinational Association of Supportive Care in Cancer, and ISU, the International Society of Oral Oncology. The guidelines I'm going to talk through are mucositis secondary to cancer therapy, oral problems in patients with advanced cancer, and xerostomia. And just really to highlight how these can inform our practice, but I think most importantly, keep us as evidence-based as possible. Next slide, please. So the great thing about these guidelines is a group of experts have got together and they've done all the really hard and time-consuming work for us. So essentially, they've retrieved all the evidence, they've reviewed the evidence and the sort of the quality of the evidence, and they've come up with some recommendations, which I'm going to talk through today. This is by no means exhaustive, so I would encourage you to get these papers if you can and have a look at them. But I'm just going to give some of the highlights from these guidelines. Next slide, please. So the first one, thinking about mucositis secondary to cancer therapy. And the key and most important recommendation, and as Joss has just beautifully highlighted, basic oral care remains the most important best practice for our patients in trying to prevent them getting oral mucositis or to support them when they have oral mucositis. And all routine actions, all the ones that Joss has talked about, include using bland mouth rinses. So the recommendation is for normal saline or sodium bicarbonate mouth rinses. And the whole point of a mouth rinse is it actually helps to clear debris from the mouth. So promoting hygiene and also trying to reduce infection. They also then go on to talk about oral care protocols and how beneficial these are for organisations to use. So oral care protocols will also include mouth care assessments, and Sonia's going to come on to talk about that a bit later. But actually, when organisations use oral care protocols, it actually helps to educate staff, it increases awareness, but it also really helps with consistency. So they're really, really beneficial to be used. Next slide, please. And then coming on to talk about specific agents. So again, as Joss has said, we do have a huge amount of agents available to us. And I think sometimes it can be a little bit overwhelming for healthcare professionals to prescribe, but also for patients to be able to know what they should be taking and when. And I think sometimes patients are recommended so many different things, often they don't really comply with any of them. So the recommendation in this guideline is that chlorhexidine is not used in the prevention of oral mucositis for patients receiving chemotherapy and radiotherapy, but it can be considered for treatment of oral infection, particularly oral candidiasis. They talk about anti-inflammatories, and benzidamine is actually the only anti-inflammatory for which there is particularly good evidence, and this is recommended for the prevention of oral mucositis. So they looked at other things such as aspirin and celecoxib and things like that, but actually it's certainly benzidamine that has the best evidence behind it. Thinking about things like coating agents, and I remember using sucralfate years ago, but actually sucralfate is no longer recommended as a coating agent. But if we're thinking about pain and discomfort in the oral cavity, there are a few good research studies now that have actually used topical morphine mouthwash. And this guideline suggests that it is recommended for the pain and discomfort from oral mucositis, particularly for patients with head and neck cancer who are having chemotherapy and radiotherapy. And in these studies, actually, sorry, I'm just going to say a quick bit more about the morphine mouthwash. In these studies, actually, the pharmacy departments made up these morphine mouthwashes for the teams, making it to a 0% mouthwash, and the patients used 10 to 15 mils about 6 times a day. Thanks, Sonia. Next slide, please. Thinking about cryotherapy or ice chips, which I know are sometimes recommended for patients to suck to try to cause kind of vasoconstriction in the mouth to stop the impact of particularly chemotherapy. However, really the only evidence for cryotherapy or ice chips is for patients having hematopoietic stem cell transplantation with high-dose melphalan, or when patients are having bolus 5-FU chemotherapy and the ice has to be sucked for the 30 minutes of the bolus 5-FU chemotherapy. So essentially, ice is not particularly considered something that we should be recommending. Next slide, please. And then photobiomodulation, or PBM, which is new and really, really exciting treatment that is being used a lot more now. So PBM is about using low-level laser light therapy, and it helps to kind of prevent breakdown in the oral cavity and to promote healing. And it's being used a lot more widely now, particularly for patients with head and neck cancer who are receiving chemotherapy and radiotherapy, but also patients who are having stem cell transplants. You can see here the lady's using an intraoral paddle, so a paddle that goes inside the mouth, but you can also get external paddles. The issue sometimes with the intraoral paddles, if people have got maybe trismus and they can't open their mouth wide enough, it can be problematic. The great thing about this is there are very, very few side effects. There's possibly some concern with late effects and whether the light therapy is carcinogenic, but there's no confirmed evidence to kind of say this. So actually, this is a really great therapy, and I hope we'll be seeing more of it. Next slide, please. The next guideline I'd like to talk about is oral problems in advanced cancer. So maybe not necessarily mucositis, but I think it's really important to talk about because it's such a Cinderella symptom. I think when we're looking after patients in palliative care teams, or when patients have moved to more a palliative focus of their treatment or their care, we tend to focus on the key things like pain and nausea and vomiting and constipation. And I think it's really easy to forget oral problems, but we really need to be focused on these as well. Again, very common in patients with advanced cancer, lots of contributing factors. And again, some things that Joss has talked about, patients becoming a lot more fatigued. Maybe they can't independently manage their basic oral care anymore. Psychological issues really may impact on patients being able to perform their own mouth care. I think there's other things that can contribute, and certainly with this group of patients, we use a lot more anticholinergic medications, and these medications can certainly cause dry mouth and xerostomia, which again bring their own problems. So we mustn't be forgetting these. Next slide, please. So what can we do about it? Well, again, regular assessment, we keep coming back to this, don't we, is absolutely key. And a regular oral hygiene regimen and support for dependent patients is really important. So as well as helping to manage pain and sickness and things, we need to be thinking about oral care. We also should be thinking about referring patients with resistant oral problems to specialists such as Joss, people like that. And I think sometimes, again, we forget about these things when patients have more advanced disease or where they're nearing the end of their life. But sometimes advice from specialists is really, really key. Again, we need to treat and wherever possible, manage the underlying problems such as xerostomia, and certainly things like poor fitting dentures where patients lose weight. Often their dentures don't fit as well, and that can be problematic. Next slide, please. So what can we do about it? Again, bland mouth rinses, so normal saline or sodium bicarbonate, and again, topical analgesia for pain in the oral cavity. These are all recommended within this guidelines. There is some talk about doxepin, which I've actually never seen used in the UK, but I think it's used elsewhere. And there is some evidence to suggest that this can be helpful topically. The strength that will be used will be 25 milligrams per ml. There is actually limited role for topical steroids, so they're no longer recommended. If oral cavity pain is quite severe, we should be considering systemic analgesia, but remembering all the issues that go with that and the side effects. We should also be considering the use of antifungal medications for oral candidiasis, so things like polyenes, nystatin, or azoles, fluconazole. However, it's so important to be assessing properly, because often you look in someone's mouth and you think, oh, they've got thrush just because they've got a coated tongue. Actually, it's really important to be doing that proper assessment. And again, Sonia's going to talk about assessing the oral cavity, and we should only be prescribing these medications if we're very clear that there is thrush present. Chlorhexidine can be used for plaque removal if patients are unable to clean their teeth with a toothbrush. It should be used twice a day. But again, as Joss has said, it's important to be using, if patients are using a toothpaste, not to be using these at the same time. Again, if patients are having nystatin, it's really important that nystatin isn't used within half an hour of chlorhexidine because they limit each other's efficacy. And again, there's no point having a lovely clean oral cavity if dentures aren't removed and cleaned as well. So really important to do this. Next slide, please. And I really like this guideline on oral care and advanced cancer because not only does it have recommendations of things to do, it has recommendations of things to no longer do. And I'm old enough to remember lots of these things being recommended. So we really need to be avoiding acidic artificial saliva. Again, going back to Joss's talk about the pH, really important. The lemon and glycerin swabs, I don't know if anybody remembers them, but we really shouldn't be using these anymore. They're not beneficial for the oral cavity. Ice chips, they can be used for comfort, but actually ice chips there is no more beneficial than just giving a patient a sip of water. And then we come on to pineapple. So we always used to say, didn't we, that pineapple had some sort of funny enzyme in that helped to clear the oral cavity. Absolutely not. We shouldn't be recommending. If people want to eat pineapple, that's absolutely fine, but it's not something that we should be recommending for oral hygiene. And also vitamin C tablets. So I know it used to be that it was recommended to put a vitamin C tablet on someone's tongue to clear debris. That can cause kind of discomfort and burning. So we shouldn't be doing that, nor should we be suggesting sucking sweets to stimulate saliva. Next slide, please. And finally, on to xerostomia and the guideline for xerostomia. So when we're assessing somebody for a dry mouth, it's really important that we're assessing them objectively. So thinking about their saliva and the quality of their saliva and the amount of their saliva. But we also really need to be thinking about the subjective sensation of the dry mouth. And we need to be asking patients about this. And we need to be asking them how much it's bothering them, and particularly how much it's having an impact on their daily living. We know that the main causes of xerostomia in this group of patients is radiotherapy to the head and neck. And certainly radiotherapy regimens have changed a lot over the years. IMRT regimens now really do try to sort of spare the salivary glands more, but generally on the whole, all patients who have radiotherapy to the head and neck will have a degree of xerostomia. But the other thing is medications, and I mentioned the anticholinergic medications again earlier. That's a very common cause of xerostomia. Next slide, please. So what about the management? What does the guideline suggest for that? Well, where possible, we should be trying to stimulate saliva rather than just replace it. And there are various ways we can do that. So chewing gum can be very beneficial if patients are able to chew it. It should be sugar-free, but that can really stimulate saliva. We can also use pilocarpine. So pilocarpine is a parasympathomimetic drug. It stimulates saliva. You can actually use the eye drops intraorally 3 times a day, or it comes as tablets that can also be taken 3 times a day. If you've got somebody that's had radiotherapy, there's no point giving them the eye drops. It just won't work for them. They do need the tablets, but unfortunately they do take quite a long time to take effect. So you need to encourage patients to persevere with them. Again, artificial saliva replacements, where possible, it's been suggested that the mucin-based ones are preferred over cellulose. They tend to work a little better, but we need to be really careful because some of them do contain porcine. So if culturally people can't eat pork, or if they're vegetarian, it's really important to be making them aware of that. Mechanical stimulation has been studied of the parotid and submandibular glands. However, at the moment, there's very little evidence for this, and there's very little evidence actually on technique. At the moment, there isn't enough evidence to suggest acupuncture or PBM for xerostomia, but there's a lot of trials in progress. There's actually been a lot of research that's been done on acupuncture for xerostomia, but the trials are really, really quite small. So I think really we need to watch this space. Next slide, please. So in summary from me, I think it's fair to say, and I hope Joss would agree, that basic oral care underpins the best recommended practice across all of these guidelines. Patients need to be assessed, educated and supported to manage this at all stages of their disease. And I think we need to be really careful, and we really need to be considerate with regard to the products we use, the advice we give, and the support to use them, and maybe not burdening people with too many products. Next slide, please. So this is one of my favourite phrases. The drugs don't work in patients who don't take them. Well, the mouthwashes won't work in patients who don't use them. So let's kind of keep it minimal, but support patients to use them wherever possible. Thanks very much.
Thank you so much, Jo. That's a really interesting talk. Over to you, Sonia, for the next session. Go ahead.
Hi, thank you very much for inviting me to do this session. I just wanted to highlight what Joss and Jo have said, and despite all of the information and all the research, oral mucositis and care of the mouth remains a neglected task. These are old references, but nothing much has changed, and it's still one of the poorly achieved tasks that we do for patients who come into oncology, whether they're an outpatient or whether they're an inpatient. So it's really worth remembering this as one of the key fundamentals for caring for our patients, because everybody deserves this basic human right. So in relation to our patients who may come in through any route, they may be being cared for as an outpatient or an inpatient, it's really important to do a pre-treatment morbidity assessment. So thinking about who's in front of you and what are the underlying issues. Have they got any poor oral hygiene, or have they got poor nutrition from the outset? Do they smoke? Are they taking alcohol? How old they are? Because as Jo and Joseph intimated, people do often get a dry mouth as they age, and they may be on polypharmacy that's already giving them issues in relation to changes within the oral cavity. Thinking about their dental history, thinking about a planned treatment pathway, and what things can we manipulate while they're on treatment, and thinking about if they're in hospital, what's happening with oxygen therapy, is it humidified, and what are the other comorbidities like diabetes that may impact on their oral mucosa, and thinking also tailoring our education to the educational requirements of the individual, and also if they have special requirements in relation to how they take on information. And obviously these really do have a significant impact on the severity and the length of the mucositis. So it's important to just reflect on what Joss and Jo have said. So thinking about your two groups of patients, some will have teeth, so dentate patients, thinking about a dental assessment at the outset, so knowing what your baseline is. Encourage those patients who are having outpatient treatments to have regular dental checks, or if they're about to embark on treatment and they're having oral SATs, or they're going to have radiotherapy to the oral cavity, obviously we'll do that from a head and neck perspective. They will already get a specialist dental review because they may need extractions. But for anyone who's having regular cytotoxic treatments or kinase inhibitors or immunotherapy, please encourage them to go to their regular dentist to make sure that they're getting regular checkups. Obviously for any extractions they would need antibiotic cover, and in relation to head and neck for the radiotherapy, it is important to remember the 14-day rule post extraction and making sure those sockets are healed. Fluoride is crucial. I won't go into that, it's already been discussed, and thinking about how you wash, and thinking also about SLS within products, making sure some patients might go for a higher fluoride, but you have to be aware that the SLS within those products may cause burning and may mean that patients are non-compliant. And the sort of the gold standard is saline and salt water washes as a regular rinsing procedure for any patient in relation to looking after their mouth. And this is to empower them. This is about giving them the tools during their treatment. And if they haven't got any teeth, thinking about examining the oral cavity exactly the same, inspecting the dentition if they've got it, and making sure that they clean it in the right way. As Joss said, there's lots of products techniques out there, but making sure we don't do the old things of scrubbing out those dentures, because what they do is they leave breaks or scratches within the actual denture, which would harbour bacteria and put our patients at risk. And remember, they should clean their dentures like they're cleaning their teeth, so it's really important. And always treat oral infection, making sure you treat the denture as well as the oral cavity. So a question for all of you listening, because obviously it's difficult when it's a webinar, but I wanted to make you think about, do you use an assessment tool? If you don't, why not? And if so, if you do use a tool, which assessment tool do you use? Does everyone use the same tool? And how often do you assess the oral cavity? And why did you choose that tool? So there are large amount of tools out there. As you can see, there's a lot of them. But the sort of the gold standard is the World Health Organization assessment tool. It's the most widely used instrument. It looks at all the components of the impact of oral complications. So it's the subjective, it's also the objective, and it's the functional impact, which is really key because we all know that nutrition and hydration are key for anyone to continue with any treatment. And if these start to change because of oral mucositis, it can have a devastatingly domino effect on that patient. As I said, it's a widely regarded gold standard. It's never been tested for reliability, and it is the tool that we use here at the Royal Marsden. So it's important to think about your 8 points of checking your mouth. This is a common cartoon that you would have seen if you do a Google search. And the one thing that people often don't do is they don't actually check, behind the lips, upper and lower, but they also don't look at the palate, and that's where you can harbour, fungal infection. And it's really important to also remember how you're going to assess that if someone's got significant trismus, and obviously in our paediatric patients, thinking about what techniques that you can do to try and facilitate a good assessment of this cavity. Now, this is an old definition, but it's a good one. It's really important to know what oral mucositis is, and it's obviously an inflammatory response with the mucosa resulting in ulceration that may or may not be evident. So we know that damage underneath the mucosa is occurring, and you may not have any visible ulceration. You might get someone saying if they've got a really extremely sore mouth, but you can't see anything visible, but the damage is being done in the lower layers, and it is severe. It causes discomfort, it causes pain, it causes dysphagia, and impairs the ability of the patient to eat, drink, and swallow, and that is profound. And we know that this is also the biggest flourishing area to introduce infection, putting our patients at great risk of bacterial infection and sepsis, and we know that this can potentially be fatal in some of our patients. This is the oral assessment grading tool, and as you can see, it's got the functionality of all three. And I apologise to anyone who is not white-facing that these pictures are very much of white patients, but just to say that in relation to the ulceration and the grading, this has got there, and what I would say is we do need more pictorial evidence of people who are not white-facing. But just the word erythema means redness, but that wouldn't be common in some of our patients of colour. You may see a darkening within the side of the mouth or on the tongue, and just to be aware of those signs and symptoms which would present differently. So in relation to assessment, it's really important that you think about doing those assessments, and it should be done on a daily basis for people who are in patients, and thinking about what's happening with that patient. So think about, what's their ability to eat. In hemato-oncology, do they have any bleeding? Do they have any scalloping? Because that's one of the first signs of when the oral mucosa is changing. What's their saliva like? Is it absent? Is it prolific? Is it stringy? How are you going to deal with that? What techniques are you going to use? What's the degree of pain? Is there any dryness? Is there any already starting issues with difficulty in swallowing? And what's their taste like? They often get a rancid dysgeusia and really hard, and that also puts them off eating and drinking. We've talked about the 8 sites to look at and looking for changes within the colour within the mucosa, and determine the score, the WHO score, so that you can grade it. And what I would say is making sure that everyone's using the same tool, because that makes sure that you're assessing correctly. So we know that this is one of the most debilitating symptoms that patients have. It is the most common, it's the most unreported. It's more common in patients who are having head and neck cancers because of the area that is being treated, but we know that it's evident within the hemato-oncology arena, but we're also seeing it with all the newer treatments and people having multiple treatments. So it's really important we assess that mucosa, but also educate our patients at the outset. We know that it's acute, it's self-limiting, it is frequently reported by patients as the most debilitating, as I've said, and it can have a detrimental effect on when they get their SATs or their cyclical chemotherapies. It may delay, and it may have an impact on their overall survival. It's a major catalyst for secondary complications. It's not just about infection, it's about the fact that they may get other things like diarrhea, malnutrition, cachexia, dehydration, renal failure, and often requiring intensive and costly inpatient supportive care, where if you do the education at the beginning, you may have a positive impact at those patients not being admitted. And obviously it profoundly affects their quality of life. So the stats are that remains unreported, it's underappreciated, and I think that's by healthcare professionals. And it's not just about nursing, it's about every single healthcare professional who sees a patient. It's their responsibility to make sure that they're recognising and actioning any oral mucositis. So thinking about the pathophysiology of 4 stages of oral mucositis, just to say that there is a process. This is a pictorial evidence of this. And often we say that people think it's, they present with sort of ulceration on the lateral border of the tongue. They think it's one ulcer, but it's actually thousands of ulcers. And pain is obviously significant when this happens. And what we're doing is we're damaging the replacement cells to replace those that are knocked off on a regular daily basis. So the physical impact of this symptom is that it does have an impact on their nutrition and hydration. It can lead also, if they've got physical problems, it can have a domino effect on their ability to do oral care, as Joss said, but it's about our responsibility as an inpatient to make sure that we're doing that on a regular basis, and it's part of our harm-free care initiative. Thinking about how it affects their communication, it then will affect their hydration and nutrition. That can also be exacerbated if they have uncontrolled nausea and vomiting. So if you vomit and you've got oral mucositis, it's like battery acid, and it's significant. And thinking about what that would have then on their biochemistry, and then again how that would affect them generally. It also increases anxiety and fatigue, which we know has a domino effect on an individual anyway. The psychosocial impact is often something that we are aware of, but we don't normally share about it. So it's really important thinking about quality of life, thinking about looking out for disengagement, socialization. You know, you've got great big stringy secretions coming from your mouth, you're unlikely to want to be socializing. If you can't then verbalize how you feel because you've got such pain, that may limit your ability to tell healthcare professionals or those people at home how you're managing and what your issues are. It leads to frustration, and again, it can lead to depression. The other thing is it can have a financial and economic burden if your job, and you're an outpatient having treatment, is to talk to people and engage in maybe this type of arena with Teams and Zoom. I think the other things we need to think about, especially people having long-term cyclical treatments and also people who are recovering from radiotherapy to the head and neck, is that it's that independence versus dependence, what the effect that has on the mental health of someone if they're the sort of main breadwinner in their family, or they're looking after dependents, either young or old. The ongoing side effect to remind the patient, the sort of that isolation versus socialization. We often don't talk about sex, you know, and the impact of having xerostomia or loss of saliva, being able to speak or being able to kiss. All of those things will impact on that individual. And thinking about the treatment, is it in weeks? It may take months. And obviously there may be people who have years in relation to hypersalivation or absence of saliva. And then that cyclical anticipation of people having regular treatment. And what's the impact on their speech and swallow? And that's important to use the expertise of our SALT team. So what can we do? It's what Joss and Jo have already said, basic oral hygiene, nurses leading and educating, involving our patients, try and engage patients to stop smoking, and making sure you're assessing it when they're coming in for their regular treatment, thinking about alcohol use, tailored education, and thinking about protocols that you develop with the whole MDT, not just nursing. So what are the challenges? Well, it's about being honest and the limitations what we have within oral complications, making sure we've got adequate pain relief, and thinking about post-treatment links with dentistry, allied healthcare professionals, and also letting our GPs and our primary care teams know. And I think the interventions are about collaboration, using all the resources around, thinking about national guidance, being involved in national guidance. You're all experts, you're all on here for a reason, and thinking about more, multi-centre studies, and thinking about outside the box for this very distressing symptom. So how we can do it is collaboration, rationalising of resources, utilising dental expertise, greater political voice, thinking about health promotion at the beginning, the voice of the users, talking to our patients, and thinking about further clinical trials and assessment of products. So just to conclude, I just want to say oral care and oral complications in any patient remains really serious complication in cancer care. It's one of the side effects that has a profound effect on morbidity, compliance and treatment outcomes. It can significantly lead to post-treatment oral complications that are potentially lifelong for our patients, and thinking about survivorship. And as healthcare professionals, we can make significant contributions to the management of oral mucositis and the complications, and challenge the boundaries and care we deliver. So within the limitation comes creativity. So, and that's the product Gel-X, which we thank you to Gelion for promoting it. This is a new product on the block, and just to be aware of those things that have been removed from the UK. So we don't have Episil or MuGuard anymore, and it's worth knowing about this product, which you can get from the people who've put on the webinar, which we thank. And I'd like to end with this video.
John O. I'm 57. I am married to Nikki for 37 years, and I have 4 children. I was laying in bed one night saying to Nikki, what is going on? Stage 4 cancer of the larynx and thyroid. So the options were twofold. I had to have a surgery, 11 hours, very device bolt, thyroid, 84 lymph nodes, weeks radiotherapy with a couple of shots of chemo, and on your merry way. Surgery 3 weeks after that. I was at hospital today for 14 days. They said 21. There's no way I'm staying 21 days. So I was down. And I had 3 weeks rest at home, and then I had 6 weeks radiotherapy. No thanks. Never again. 6 weeks radiotherapy to the neck. Rope and everything, and just 2 shots of chemo involved in it to try and make it work out. And probably that by the end of week 4, the mouth as dry as a bone, sores and the ulcers, and I stopped eating by that point. I was losing weight. I was a nice jolly fat man, and I was losing weight and running constantly. I couldn't sleep with even if I had ice cream, it hurt. So I dived through the box and I found this bottle of Gel-X and I started to use it. Wow. Almost instantly. So that's probably a bit of an exaggeration, but looking back, it felt like that. Everything felt better. Straight away, it gave me enough relief to start eating. I was pain-free in the mouth. Of course, there was a little bit of soreness, a little bit of aching, but I was having spaghetti bolognese, and I was telling them down the miles, and all of a sudden I was putting weight on. So when you come across a product that actually does what it does say on the tin, it's rare. Gel-X made me, I was pain-free. I ate. It avoided me having a feeding tube. It made me have a life. It was a great product. Thank you. My name's
Thank you, Sonia. And that also, I think, it's good to end the talk on a first-person perspective from a patient side of things, isn't it? I have to say, I mean, what I've seen is the significant impact of the patients, those who have suffered from mucositis, coupled with the fact that actually, unfortunately, it's not a priority for clinicians. It's often ignored, isn't it, by clinicians, the issues of mucositis. And I often have discussions with my medical nursing colleagues to say that it's not just quality of life. I would say it affects treatment compliance. If you've got severe mucositis, if you can't take the medications, it indirectly affects prognosis for many of our cancer patients. So this is such an important topic. So I'll get on to the questions. We've got about roughly 10 minutes before the end of the session. So we've got some questions by email, and I'm sure we've got some more questions on the chat. But feel free to put more questions, guys. And can I also ask to the three speakers, if we don't have time to go through all the questions, can the audience email you if they have any specific questions or
definitely.
advice? Perfect. So my first question, from the audience is from Joss, an interesting one. How easy is it to get a dental review in a timely way? Any tips to jump the queue? I'm assuming it's about, are there any national standards that
there aren't at present, unfortunately. Right. What I'm trying to do when I lecture is I sort of encourage people to work as a team. If somebody rings you and calls you to say, please, can I have a check? Even if they're not able to have a check, if they're able to get oral hygiene advice to at least help them, either getting products to help them, so with the high fluoride toothpaste, or suggestions, or literally just basic oral care. It's a very tricky one. And no, I don't have an answer to you there, unfortunately, but I would like, there are things rumbling about. Obviously, patients are going to move from 1 in 3 to 1 in 2. So we're going to have a real problem with patients with oral care and oral problems later on. So ring your dental care professionals, ring your NHS practices, tell them that you're about to start your treatment, you've had a diagnosis, and can they help you? And then see what they can say. And I hope that somebody will say, yes, come in and let me have a look. So unfortunately, it's a bit of a wishy-washy answer. I do apologise.
No, that's helpful. So the bottom line is have closer collaboration with your local dental team, I gather. So Sonia, I think you wanted to jump in.
I think it's also, just to add on to Joss, I think it's also, we need to start before. We need to educate children about the value of oral hygiene. We've got to start with younger people, and we've already got to really try and get people to have a dentist, because no one ever knows if they're going to get a diagnosis. And the other thing I would probably say is that they contact a dentist to say they've had a diagnosis, and they do need to see a dental hygienist, because I think that's that way of, going to a dental practice to say, I'm in a pickle, I do need support. I think you could do that, but I think we have to go upstream. I think it's making sure that it should be a national agenda that everyone has a dentist, and we encourage children to do this, because they're the ones that change the narrative in the next decade.
Yeah,
thanks.
I agree, absolutely.
So the next question is for Joe. Joe, lot of interest around photobiomodulation, PBM. We have said the Christie, we piloted it for some of our head and neck patients, and there were really very positive results. The question is about how widespread is PBM? Is it extensively used for mucositis in the UK?
Do you know, I have to say, unfortunately, I don't know which centres have got PBM machines. I mean, I would imagine that most of the large oncology centres do now. I mean, we're the third largest centre in the UK, and we've got one machine. I don't know how many you've got, Ash, at the Christie or at the Marsden. Sonia, how many you've got? Just the one, yeah. So I think it's probably not used as extensively as it should be. Hopefully, more research coming out will highlight the real benefits from it. And I think the fact that you're not using another drug, as far as we know, hopefully there's no side effects. I know that the longer term stuff at the moment we're not so clear about. So I don't think it's used as widely as it should be, unfortunately. But yeah.
Thanks, Joe. Sonia, did you want to add to that?
Yeah, just to say that Emma Helen's been doing it for a long time, and she's sort of a therapeutic radiographer using it for late effects. And I think obviously we've started using it in adults, so it's a study in adults and pediatrics, but I think it's sort of raising that awareness, and obviously we're sort of following suit because the Christie are using it, and I think it's just being aware of it, because it's easier to get licensing, because it's not sort of the laser legislation that we had before, so it comes under a different caveat. But if you want to know anything about it, they obviously do contact either the Christie, the Marsden, or we Joe as well, to find out more. But there is a lot of data coming through, but we look forward to sort of more rich data.
Yeah, I think it's being used in paediatrics a lot. Ash, do you remember the talk at UCASC last year? There was an amazing dentist she's doing her PhD, and she did it, and you know, for the children having stem cell transplants and bone marrow transplants, actually it was kind of fantastic, and I think a lot of them found it quite exciting. Actually, I think somebody I saw a question pop up, so I'm going to maybe answer it. Something about protocols within that mask guideline. Actually, I did, you know, there's so much detail in there. The one for mucositis, they detail 3 different kind of protocols for PBM, so it's worth trying to get that paper. It's in Supportive Care in Cancer, and that actually kind of lists the different protocols that you can use and the different sort of frequencies of light and things like that. So that's a good place to have a look for that.
Thank you, Jo and Sonia. And I would add that my understanding is PBM is now part of the NICE guidelines for mucositis. So that's one way of getting your trusts to try or pilot it. And as far as I'm aware, the manufacturers of PBM will lend the machine for a few months so they can pilot a project, see if it's effective or not. And Sonia's right. Emma Hallam, based in is it Nottingham, if I'm right?
I think it's Sheffield Hallam, isn't it? Is she at Sheffield Hallam? Well, I don't know.
I remember, but Emma is a very renowned authority. Yeah, someone said Nottingham there. A renowned authority on PBM. And I remember going to the MASS conference last year, and the French are way ahead of us in the use of PBM. They're using PBM for pretty much, you know, any symptom. And I think one of the benefits of PBM is the side effect profile is hardly non-existent. So it's worth considering that. Okay, just one last question, just mindful of time, to Sonia. How to distinguish oral mucositis and pharyngeal mucositis from a clinical inspection, clinical perspective? Is there anything that'll help us to distinguish between the 2 mucositis, Sonia?
Well, I think you obviously got to think about your patient population, because there's only so far that you can see within the oral cavity, and anyone looking at a mouth must have a light source. That's really important. And obviously you just have to think about where the pain is, and it may be that it is at the back of the throat, and especially if you think about laryngeal radiotherapy, you might not have anything in the oral cavity, but it might be down in the oropharynx area. So I think it's just about thinking about it, but obviously your techniques, and if someone can gargle without having a risk of aspiration, then that's important, but you really need to think about the safety aspects of it. But it would be good pain control and assessment, and obviously just sort of navigating them through that and making sure they can use other techniques which may facilitate them, steaming, for example, as well. I hope that's helpful.
Great, thanks, Sonia. I think I'll go back to what you mentioned in the slides about the importance of using a standardized tool for assessment. And I found the WHO tool really helpful. I think that's all we have time for, but I have to say once again, thank you to all 3 speakers, Josh, Jo and Sonia. Really, really interesting talk. I've learned a lot. I'm going to implement some of that in my practice. And a special thanks to Galen, who sponsored this event, and to Elaine Tomlins, our nurse consultant who has organised this event. Thank you, everyone. Again, just to reiterate, if there are any more questions, please do email the speakers if you have got any specific questions around that. But once again, thank you. I think that's the end of the session.
Ash.
Thank you. Bye.